Next talk, we will have hard pattern issue to testosterone, not to testosterone. Dr. Aaron Redding will give the talk. And Dr. Aaron Redding graduated from Louisiana State University, and later on, for some reason, he went back to the same place to get his endocrine fellowship. And since then, he just moved to Little Rock, staying ARDC, and right now he's the bedrock of our practice. Look after him. So,
thank you.
Yeah.
I think that's another way of saying I'm the oldest. The previous retired. Yeah, so I think I can get us on track just a little bit. I'm from Mississippi and Louisiana, so I can't talk fast, so I'll just talk a little bit less. I do have a couple of cliffhangers in here, so if you've already downloaded the digital form of this, you're out of luck. If you haven't, anticipation. So anyway, so to testosterone or not to testosterone, kind of quickly, the symptoms are kind of vague. Decreased vigor and desire to complete projects, decrease in libido, depressed mood. Later symptoms, you'll lose some muscle mass and some body hair, which I think I've just described with a lot of the men that I see in my practice. So pretty vague. As far as the diagnosis of it goes, it's pretty simple-ish. It's a subnormal testosterone and or sperm count. They tend to go hand in hand, although they don't necessarily have to. Normal range is between 300 and 800 nanograms per deciliter, although that may change a little bit depending on what lab you use. When a man comes in with these testosterone levels and they're low, he hands them to me and says, "Oh, let's treat." So the question that comes to my mind is, well, is it really low? And there's a couple of things to take a look at, and one of them is, well, what time was the blood drawn? And that's important. This is a diurnal variation of testosterone levels. As you can see, at 8 a.m. it's at its peak. At about 8 p.m. it's at the nadir. Much more of that with the younger men as opposed to the older men. But this is why the insurance companies require you to get 2 before 9 a.m. and not at any time during the day. So timing is important. What time is it drawn? Yes, before 9 a.m. The next question that I ask is, do I need a free testosterone level? So that leads me to this. So when we get a total testosterone level, this is kind of what you're looking at. About 50 to 60% of that testosterone level is bound to sex hormone binding globulin. Okay, the reason that's important is that's not available. Okay, that's just part of the number, but it's not available. What is available is what is weakly bound to albumin. That's about 40 to 50%, and then the free testosterone is 1 to 2%. So you can see, if you affect that sex hormone binding globulin level, you're going to make a big change in the numbers, which may lead you down the wrong path. So if something increases sex hormone binding globulin level, testosterone level may be normal, but that free testosterone level may be low, and vice versa. If something causes that sex hormone binding globulin level to be low, okay, you might start treating someone who doesn't need to be treated because their free testosterone level may be normal as can be. So, the first one, what factors increase sex hormone binding globulin? One is aging. Not really why this happened, not sure why this happens, it just happens. So we'll just accept it. Hyperthyroidism. This can be thyrotoxicosis too from somebody being overtreated with thyroid hormone. And there's hepatic nuclear factor 1 enzyme that gets sped up in the process that creates more or makes more sex hormone binding globulin. Liver disease, a lot of inflammation in the liver, and again, some enzyme processes increase the production of sex hormone binding globulin. HIV. There's nothing specific here, but it is interesting that all of the numbers and all the lab looked at mirror aging. So some folks refer to this as an accelerated aging process. That's why it increases. Seizure medication, phenytoin, carbamazepine, phenobarbital. I think you've seen a lot of those names in these talks. Those also, they increase enzyme processes in the liver and increase sex hormone binding globulin. These can really increase it. I mean, that's when you get a total testosterone back of greater than 2,000. Sex hormone binding globulin levels greater than 200. High estrogen concentration. This is actually, it's a kind of a complete sake, because I guess a lot of women are on testosterone these days. Different topic. But the estrogen tablets that first pass effect through the liver is what increases sex hormone binding globulin. So the transdermal, not that much of an effect. So, metformin. I was going to call it an insulin sensitizer, but I'm not going to do that. I learned. Okay, so here, insulin levels are inversely proportionate to sex hormone binding globulin level. Okay, so the higher the insulin level, the lower the sex hormone binding globulin level. So if you improve insulin levels, insulin resistance with metformin, okay, that sex hormone binding globulin level will go up some. Same thing is true with the true insulin sensitizer, diazolidine-diones. Lactose, pioglitazone, they'll actually increase your sex hormone binding globulin. So these are the folks that their total testosterone may look normal, but maybe that free testosterone level is low and you might miss the diagnosis. So factors that decrease sex hormone binding globulin, you're going to recognize a bunch of these. So, too much. Obesity. There's actually a syndrome, it's called MOSH, I don't know, M-O-S-H, male obesity, secondary hypogonadism. I'll talk about that later. But obesity, not fully understood here, but it also has to do with that insulin inverse relationship with the sex hormone binding globulin. Insulin resistance, diabetes, again, an inverse relationship. As a matter of fact, the sex hormone binding globulin level can be used as a marker for insulin resistance. So if you see someone with low sex hormone binding globulin, probably have insulin resistance, and you can actually use it as a predictor of who will develop type 2 diabetes. Hypothyroidism, kind of the reverse of the hyperthyroidism. Enzyme processes in the liver slow down, so you just don't make as much sex hormone binding globulin. Glucocorticoids. And you can actually add anabolic steroids, you can add progesterones to all of this. There's just an inhibition at the liver of making sex hormone binding globulin. Nephrotic syndrome, basically you're losing it in the urine. So these are the folks that will come in with a low total testosterone, but free testosterone level may be normal as could be. So methods of measuring free testosterone. It's kind of important. Equilibrium dialysis is the gold standard. I can promise you you're not getting this. This is a very expensive test, takes a long time to do. Hopefully most of us are getting this one. It's a free testosterone concentration. This is, I think most of the clinics, SBI clinics, run the lab through LRUC, and this is what you're getting. You're getting a calculation of the free testosterone based off of sex hormone binding globulin, albumin, and total testosterone, which matches pretty good with equilibrium dialysis. If you're not getting that, you're getting an analog method, which is not very accurate. It's a radioimmunoassay, probably really shouldn't be used. How can you tell the difference? Well, if you get your lab back and you have a sex hormone binding globulin level and albumin level, yeah, you're getting a calculation. Good stuff, but if you're not, that's what you're getting, and I might get it at a different lab. So, hypogonadism leads me to a low testosterone level, sperm count, lab drawn before 9 a.m. Free testosterone is if it's indicated, and the next step is cliffhanger. Treat. No. Why? Okay, why is the testosterone level low? I can't tell you how many people come in and ask them, why are you on testosterone? Oh, no. They just told me my testosterone was low and I get all these shots. So, why? That leads me to this, and this is just the hypothalamic pituitary testicular pathway. So LH stimulates the Leydig cells to produce testosterone. The negative feedback of that is testosterone. FSH stimulates the Sertoli cells and the seminiferous tubules to produce sperm. The Sertoli cell produces inhibin, which is the negative feedback. So primary hypogonadism. Low free or total testosterone, elevated LH and FSH, just like Hashimoto's, low T4, high TSH, same. The most common cliffhanger too. Most common cause of primary hypogonadism is a couple of clues. Prevalence is 1 out of every 400 to 1,000 men. 50 to 70% go undiagnosed in their lifetime. Wow. So we're seeing these people. There's an increased risk of ischemic heart disease, DVTs, pulmonary embolus, COPD, osteoporosis, higher risk of breast cancer, higher risk of autoimmune disorders, and the answer is Klinefelter. So Klinefelters, most of this is non-disjunction meiosis, either from the egg or the sperm. So egg, usually one X, sperm, usually one Y. The egg will have two X's. Now you have XXY, or it can come from the sperm, have a non-disjunction here, an X and a Y combined with the one X from the egg. So that's where that comes from. There is some mitosis version of this. It's a mosaic that actually happens in mitosis. So X, Y, but somewhere along the development, there's another non-disjunction in mitosis, and from that point forward, you'll have the XXY. But they both present the same way. I'm used to seeing, the pictures in the books of, oh, that's an obvious Klinefelters, the gynecomastia, the long legs, but this is, and people did social media these days. I got this off. Anyway, so the guy on the left, okay, he's got Klinefelters untreated, and I look at this guy, and okay, he's kind of lean, maybe. I don't see gynecomastia. I really can't tell how tall he is. But Klinefelters, testosterone therapy, a little bit of time in the gym, and there he is on the right. So, anyway, I can see why it's not diagnosed. So, other causes, primary hypogonadism, mumps. Measles, mumps, rubella vaccine came out in the 1960s, combined with the MMR in 1971. So, but a lot of the immunity kind of wanes over a period of time. There's a lot of non-vaxxers in the community that kind of come along. So you still see mumps happen. There's a mumps orchitis that happens. Radiation, this would be like treatment for lymphomas, leukemias. Even though there's proper shielding, you can still have some damage to testicular tissue. Alkylating agents like cyclophosphamide, cisplatin, used to treat head and neck cancers, lung cancers, multiple myeloma, will cause primary hypogonadism. Ceramine, I've never seen it used. It treats African sleeping sickness and river blindness. And some people have used it to treat COVID. So ceramine is parasitical disease. Ketoconazole directly inhibits the production of testosterone. Chronic illnesses, this is actually kind of a mixed thing. I put it under here, but it's also going to be under the secondary, in that these chronic diseases have a direct effect on testicular tissue as far as testosterone production. There's also some secondary effects of the pituitary. Secondary hypogonadism. Obese, let's see, free testosterone is low, and FSH and LH are low. I think this is probably where most of the men land when I see them. The causes, sleep apnea. All cells in the pituitary gland are not alike. The gonadotropes are wimps. Okay, if there's anything going on in life, physical stress, emotional stress, they shut down. Now, as far as the corticotropes making cortisol, he-man of the group. So sleep apnea, frequent awakening, no REM sleep, no rest, hypoxia, respiratory acidosis, gonadotropes just shut down. Incidentally, if you give someone with sleep apnea testosterone, you're going to make their sleep apnea worse. Also, if you take these sleep apnea people and you treat them with CPAP, only about 30% of them return to normal testosterone production. So they could still need testosterone replacement even though you fix the sleep apnea. Obesity, this is that MOSH that I was talking about. The male obesity, secondary hypogonadism. This has to do with the adipose cells aromatase activity that converts testosterone into estrogen. The estrogen then feeds back up to the pituitary gland and inhibits LH and FSH. Let's see, diabetes type 2. Again, there's that inverse relationship to the insulin and sex hormone binding globulin. The hyperprolactinemia. So to appreciate these, normal pituitary function is the lactotropes are constantly turned on to make prolactin. And they'll do so unless they're told not to by the hypothalamus by dopamine. So if you interfere with dopamine signaling, dopamine communication, prolactin level goes up. And that's the way some of these things work. So the pituitary adenoma doesn't necessarily have to make prolactin. I mean, a prolactinoma, those prolactin levels are sky high. I mean, they'll be greater than 300 at least. But if the pituitary adenoma is in a situation where it interferes with that dopamine dripping down from the hypothalamus, that prolactin level ease up 30, 40, 50, 60 or so, and that's enough to inhibit LH and FSH. The antipsychotics, they're dopamine antagonists. So they'll block that dopamine receptor and the message never gets to the cells to stop. Metoclopramide actually inhibits production. Domperidone is in the antagonist. Methyl-dopa prevents production. Verapamil. Don't really know why this happens, but verapamil will definitely increase the prolactin level. Hypothyroidism. You see this. So normal physiology again, hypothalamus TRH stimulates the pituitary gland to make TSH, which then stimulates the thyroid to make thyroid hormone. Hypothyroidism, TRH is elevated because it's telling the pituitary gland to make more TSH, so the TSH is high. Thyroid gland can't respond, so those numbers are high, but that TRH actually stimulates the lactotropes to make prolactin. So if you have an untreated hypothyroid, prolactin level a lot of times will be elevated. Chronic kidney disease, actually there's increased production of prolactin and decreased clearance because the kidney is what clears out the prolactin. Some other causes, GRH analogs, leucolide for prostate cancer. This is kind of interesting. It kind of depends on when you check the levels because this is an agonist, is what it is. So on the GnRH agonist, so the medication will latch onto the receptor, which has about 100-fold affinity compared to GnRH, and enzymatically it's not going to be enzymed away. So those receptors are actually stimulated initially. LH, FSH goes up, testosterone level goes up for about a week. And after about 3 to 4 weeks, those receptors have downregulated so much because they're under constant latching into those receptors that the testosterone levels are at castrate levels. So it kind of depends on when you check the numbers. Medications, megase, glucocorticoids, opiates, anabolic steroids, they all inhibit the release of LH and FSH. Critical illness, again, these cells are WIMPs. If you go to a hospital setting, I can assure you every man is going to have a low LH, FSH, and testosterone. So chronic illness, basically the same reason. Pituitary adenomas, cysts, empty-cella, again, just the presence of an abnormal in the pituitary gland is going to inhibit these cells from making LH and FSH. Infiltrated diseases, sarcoidosis, Langerhans, I did put hemochromatosis up here. Interesting, those are usually kind of come along with diabetes insipidus. Treatment. So expectations. I was going to try to find a funny slide here, but you already know what men's expectations are when they get testosterone. And it's completely unrealistic, and they're very disappointed in this. But so what you can expect is an increase in muscle strength and increase in fat-free mass. You can expect an increase in bone density. You can expect an increase in libido. Not erectile dysfunction, because that's a neurovascular issue, and that's the big letdown in a lot of men. Because they come back, hey, doc, it didn't work. I said, what are you expecting here? So there's increase in energy. Mood, cognition, yeah, maybe. So this is a plethora of treatment, and there's tons of it out there. I mean, you have testosterone cypionate and anthate to inject. You got patches, you got gels you put in your armpits, on your legs, on your shoulders. You got patches you can put other places. You can spray it in your nose if you want to 3 times a day. You can take a tablet if you want some hepatotoxicity, and there's a new tablet, the capsule that you can take that doesn't. I don't think I forgot any of them. This, I knew this existed, and it took me a while to find this. Okay, this is a picture of a box that contains testosterone suppositories. This one, I get this one over here to do a segue into this, but this is kind of like a pen, EpiPen, that's what thank you. It is for people with trypanophobia. Thank you for that word. Trypanophobia. Okay, fear needles. So this is just a gizmo, jab it on, takes about 10 seconds to deliver it, but it delivers it into the sub-Q tissue, which you can give testosterone in the sub-Q tissue. Segue to this. A lot of men really don't like that IM injection, so I'll get them to use a TB syringe or insulin syringe, put a 25 gauge needle on it, and that's what they have to take their time, but they can give sub-Q. So some potential adverse effects, erythrocytosis, this is the one that I see most commonly, and really that's related to the really high testosterone levels. So if you're giving the injections, which is pretty inexpensive, every 2 weeks, that first couple of days, those levels are getting pretty high. And you're gonna run into some problems with erythrocytosis. So I get hematocrit every 3 to 6 months, more often for the injectables. The symptoms of erythrocytosis, polycythemia, would be fatigue, weakness, headaches, shortness of breath. Going to the sub-Q version, okay, you cut the dose in half, maybe half of a cc every week rather than 1 cc every 2 weeks. So rather than your levels going sky high, they just go half a sky high, but you do have to give it every week. Prostate cancer doesn't cause it, but it can unmask it. So you really need a baseline PSA. Then about 3 months and in 1 year, times to refer to the urologist is if the PSA increases to greater than 1.4 nanograms per deciliter, but it will increase. Your PSA will increase when you give testosterone, but it shouldn't go up more than this or greater than 4. BPH symptoms may worsen. Acne in the younger men. Testosterone undecanoate. This is an injection that you give 4 weeks, and then you can get every 10 weeks. The problem is you run into, it's kind of rare, but it does happen, pulmonary oil microembolism, about 1.5 out of 10,000 injections, and anaphylaxis, which, we don't like to see that. Methyl testosterone, this is the old testosterone tablet. 17 alkylated, kind of goes through the liver, hepatotoxicity, it's still available, nobody uses it. Striant SR, this used to be available, it was a subbuckle that you could use. I'm gonna get back over there. I remembered something I didn't tell you. Secondary hypogonadism, I've come across 2 young men doing this. SARMs, selective androgen receptor modulators. SERMs, we know, is tamoxifen and raloxifene, acts like estrogen in some tissues, blocks the effect of estrogen in other tissues. There are SARMs that are out there. None are FDA approved, but a lot of men, younger men generally are using those to, again, it's selective androgen receptors. So some androgen receptors are being stimulated, others are being inhibited. The ones that are being stimulated are the guys that are going to the gym, trying to bulk up. It's just another way to bulk up. As far as that next one, this is just a cardiovascular safety. So a lot of concern was raised from VA studies primarily, chart studies, that maybe there was association of testosterone to coronary events. So the testosterone trials was performed in 2016. Kind of a short study, but it used transdermal testosterone daily. And they looked at 7 different endpoints. So there was increased hemoglobin, increased bone density, increased libido, sexual activity, increased ability to walk, there was no increase in coronary events, but there was an increase in non-calcified blockages. And nobody really knows what that means. But now we've had some of these studies, and this is just a cardiovascular. This came out a couple of months ago in New England Journal, and this is from the cardiologist. But they took, I'll just kind of ride down to the conclusion, middle-aged and older men, hypogonadism with pre-existing cardiovascular disease or increased cardiovascular risk was treated daily with the transdermal, and for about 2 years, and it's a non-inferiority, so no events in those men. I bring this one up if we are going to treat men with cardiovascular risk, it's probably a better idea to use the transdermal rather than the injections to avoid these high testosterone levels. I don't shy away from compounded testosterone. It's the least expensive version for all the Medicare folks who that's going to treat, about $45 a month or so. That's all I got. So I'll entertain any questions.